So much to our panelists and our speakers for the enlightening discourse.
Now we would like to proceed with the last speaker of this session, which is Dr. Aisha Latif. Dr. Latif is currently Chief of Medicine at Woodlands Health and Adjunct Associate Professor at National University of Singapore. Please welcome Dr. Aisha Latif, who will be speaking on lupus mimics.
So good morning and assalamu alaikum everyone. A word of thanks to the organizer for inviting me back. It's really a wonderful feeling to be back after a bit of break due to COVID. And congratulations to PSR on this milestone of Silver Jubilee. It's really a proud moment to be part of it. I really have seen rheumatology growing in my association with PSR over the last few years. So it's really very happy moment. So I was asked to talk about mimics of lupus. And as we heard from our two speakers this morning, very elegantly shown how heterogeneous the disease is. There's no single etiology, there's no single manifestation. This is a disease of many faces, right? One of the greatest mimickers, we all know heterogeneous presentations, often multi-system. But they are non-specific most of the time. So how do you then put a handle to it? We are just, through the panel discussion and case-based discussions, we have realized there are real-life scenarios for which no evidence prepares you. So what do you do? So it is a situation where clinical acumen is required. And that's why we as rheumatologists still have jobs, right? Because we can't be replaced yet by algorithms. Lupus remains one of the topmost conditions where it can be missed, and yet there is a real risk of overdiagnosis. So what do we do in real-life situation when you are faced with a patient who have a multi-system presentation? Do you go by classification criteria? And there are many of them now, right? The latest one a few years back, ULAR ACR, so now the world authorities have agreed, and it is about 96% sensitivity, and it is pretty specific, 93%. Can we apply that in clinical situation? And I understand that there are family physicians, residents, and medical students here, so I'm more pitched at them to let them see how rheumatologists functions. Should we apply classification criteria? Answer is no, because they are meant for research. They are supposed to pick up groups of patients, homogeneous populations for research. And even the authors of the criteria themselves says they are not diagnostic. Okay? Diagnostic criteria is dangerous. You need 100% sensitivity and specificity. And what did they say? What is the gold standard? The gold standard remains, sorry, I can't seem to get the, okay, never mind. The last line, gold standard of expert physician diagnosis. Okay, right? So what's the gold standard for lupus? Expert physician diagnosis. So let's try and pretend that we are the experts. Don't know we are or not. So I'm going to just take you through some case scenarios. Must say that I am a pure clinician. I do dabble a little bit on research, but to me, clinical medicine is where my strength lies. And I hope to have some responses from the audience. Otherwise, I'm going to look at those students I can see sitting here. Okay, so some case-based scenarios. Let's talk about this, whether this is lupus or not. So we have a youngish woman, no significant past medical history. She presents with fever and joint pain in hands for 3 weeks, and rash, which is for 5 days. Febrile, high temperature. Take note of the temperature. She has got a facial rash, which is malar in distribution. And let me show you the rash. And she has some joint tenderness and some lymphadenopathy. Lupus? Not lupus? Investigations. She's got cytopenia. All cell lines are down. Pancytopenia. Liver is affected. Albumin is low. ESR is high. Anyone wants to volunteer anything? She gets an ANA, it's positive. Lupus? Lupus? Could be. What else it could be? Even complement is low. Sure? Lupus? Agree? I give you a bit more history. She's a preschool teacher, and 2 kids in her class have recently been unwell. What are the red flags, right? So exposure history, the contact history, as well as the short, very short presentation, 3 weeks. 3 weeks, right? She's not lupus. So what's the diagnosis? Parvovirus, right? We almost got caught out. Lupus mimic. There are features that are similar. And all this can happen in parvovirus infection. There are features that differentiate, but they're good to know, but they're not going to help you in that particular patient because they are just not there, and not every lupus patient is going to have everything. So we almost got caught up. The other thing to remember, fever was 39 degrees. Pure lupus will not do that, right? So this was an infection, not lupus. Another one, 32-year-old male, joint pain for 2 months now, not 3 weeks. Inflammatory, small and large joints. Now we are very careful. We are going to ask more history. We just got caught up by that 3-week history. Loss of weight, 5 kg in 6 months, significant. He's got dry mouth for 3 months. More and more lupus-y flavor coming in. Rashes, right? He's telling you my joints hurt. Physical exam. He's afebrile, no 39 degrees temperature. Normal hemodynamics. Multiple joints, small and large. They're tender, they're not swollen. He has reduced tear and saliva film. And he has diffuse erythematous rashes. Lupus? Again, bicytopenia, right? 2 cell lines are affected. ESR, sky high. Albumin, low. Cret is normal. Anything else? Okay, you get it? Positive. Also rheumatoid factor, positive. So our scenario is a young man with inflammatory polyarthritis, rashes, Zika symptoms, and weight loss. He is bicytopenic, he has raised inflammatory markers, and he has positive serologies. Take your pick. Lupus, RA, Sjogren's, overlap. Sjogren's? House consensus seems to be Sjogren's. Yes, there's a raised hand there. Sorry, I can't hear you. Sjogren's. Sjogren's. Okay. House consensus. Yes. Excellent. There are other possibilities. Yeah? Okay, we are all physicians before being rheumatologists. Don't lose track of that. People can have other things. Let me give you a bit more. Unemployed, lives alone. In our context, Singapore context, by the way, these are all real cases. No intravenous drug abuse now, but did it in the past when he was young. No family history. And then you look carefully at the rashes again, and this is what you see. So what is it? Vasculitic rash, purpuric, vasculitic looking rash, not your classic lupus Sjogren's rash, right? Someone said infection. Can we have the mic there, please? What were the thoughts there?
A serology for viral hepatitis and HIV serology as well. Because in this context, we have to consider cryoglobulinemia and diffuse infiltrative lymphatic syndrome, which might lead to dry eyes and dry mouth in the presence of HIV as well.
Excellent. Are you a rheumatologist by any chance?
Yes, I am.
Excellent. Yes. So we did further tests. He was even CCP negative, DNA negative, ROLA negative, complements were normal. They were fragmented RBCs. So he's having intravascular hemolysis as well. You have just answered it. HCV positive. Viral load very high. Cryoglobulins positive. What he has? Hep C with immune-mediated extrahepatic manifestation. In this case, multiple cryoglobulinic vasculitis, giving rise to that rashes that you have seen, arthralgias, positive serologies, as well as intravascular hemolysis, right? So remember, infections can mimic in many ways, especially in the Hep C setting. Hep C has a lymphocytic lymphotrophism. It binds to CD11, and there's the same mechanism. It causes polyclonal B cell activation, then can give rise to antibody production. And there are lots of antibodies that can be positive. You can see a lot of patients will have RF, ANA that our patient has. People can even have cardiolipins. And there is a real risk of progression to lymphoproliferative disorders. So watch out. Another infection. We almost believed that it was Sjogren's, right? So infections can really mimic. And it's not just this. There are other infections, as was just pointed out, HIV being one of them. In HIV specifically, there are two phases. It can be associated with rheumatic diseases, but also the treatment itself can, with the reconstitution of the immune system, there can be certain diseases that can become manifest. That have been hidden by HIV infection, and lupus is one of them. So remember that, okay? So infectious diseases mimicking lupus, viruses, we saw 2 cases. I mean, I can't go on every case, but just to remember, parvovirus, CMV, EBV, hepatitis, HIV, and COVID. And COVID vaccination. I'm not sure about here, but in Singapore, the entire population, I would say 99% was vaccinated with RNA vaccines, and we are seeing a lot of immune-mediated manifestations. TB remains one of the biggest mimicker. Take-home message, infections can mimic, serologies can be misleading, employ tests, but remember, treat the patient, not the test, and consider infection when it's not your typical garden variety. Another one, and I have 5 minutes left. 35-year-old female, fever, weight loss, rashes, hand pain, lumps in the neck. This is her hands, not sure very clear, but some vasculitic-looking rash, a lump. She has already seen a GP, again, same story, cytopenias, ESR, which is crossing 100, albumin is low, she's seropositive, she has been prescribed steroids by her GP, she has not started yet. What will you suggest? Okay, in the interest of time, I will move on. We got her a scan done because lymphadenopathy was extensive. And then what we did a lymph node biopsy. And here it is, small lymphocytic lymphoma, okay? Lymphadenopathy is common in SLE. It's reported in up to a quarter to 3/4. But remember, if it's generalized, there's concomitant hepatosplenomegaly or B symptoms. Watch out. Again, autoantibodies, lowest specificity. Okay, again, same thing. So watch out. Another case. Fever for 10 days, red spots, erythema nodosum basically, ESR high, ANA positive, very, very high. Fatigue, myalgias, oral ulcers, weight loss. I mean, this one I agree on. It looks lupus. She got treated with steroids and plaquenil, and then she disappears on us. She wasn't too sick. Comes back 6 months later. High-grade fever, pancytopenia, got labeled as severe lupus flare with neutropenic infection, fever. She worsened, developed MAS, macrophage activation syndrome-like thing. She was in ICU, being supported, and because of MAS, we got a bone marrow biopsy. And what did the bone marrow biopsy show? And then her rashes get biopsied. And what does that show? Lymphoma, okay? So SLE mimics a lot. Infections is just one group, neoplasms, lymphoproliferative disorders top the list, but there can be non-malignant conditions like Kikuchi's disease. Other rheumatologic diseases can mimic lupus, like vasculitis, stills, dermatologic, endocrine. Okay, let's one more because I'm running out of time. 44-year-old, 2 years of recurrent rashes, okay? He gets treated with psoriasis, everything, not responding very well. The rashes are bad, so the dermatologist gave everything, including TNF inhibitors. 3 months later, joint pain, okay, psoriatic arthritis maybe, feet swelling, pruritic chest pain, pitting pedal edema, inflamed joints, RFCCP negative, ESR very high, urine dipstick is showing 2+ protein. This is the chest X-ray, this is the CT thorax. Okay, again, in the interest of time, I'll just tell you, increased reticular markings is concerns about interstitial lung disease. Quick, any takers? So middle-aged women, long-standing rashes, new onset synovitis, proteinuria, ILD, after use of TNF inhibitors. Drug-induced lupus, don't forget that, okay? Common, there are different grades of associations depending on the drug. Again, this is an ever-expanding list. You all can read it. In the interest of time, I'm going to run through it. Clinical picture is usually milder. Renal disease is uncommon, but again, in this particular patient, it did happen. And there are certain guidelines and criteria to consider for drug-induced lupus. Okay, just last one. Interesting. 28-year-old female, this was my patient. First admission, she comes in to general surgery, no past medical history. Look at this. Guiding, voluntary, surgeons, sorry if there's any surgeon in the, I'm physician. Plus minus rebound. History is very short-lived. They get her a scan. And the scan did show that dilatation, thickening, some hydronephrosis. She gets treated as GE, enterocolitis, antibiotics, bowel rest. She gets better. And then over time, repeated admissions, sometimes under gynae, sometimes under medicine, sometimes under surgery, different labels. Develop alopecia in second trimester, real photo, told pregnancy-related. She gets a breach, she gets LSCS. So we have a gynecologist sitting here. The next day, she develops intractable vomiting, abdominal distension. Okay, my time is up. Anyway, she has puffed. Basically, she was lupus. So the other flip end, I said we can miss it, and we missed it. She was lupus gut, borderline proteinuria, alopecia, serologies, low complements. So not all lupuses present with the typical classification criteria. Take a pinch of salt. They are not for diagnosis. There are people who are incomplete SLEs, and they do progress, and they can have severe disease. So just keep it in mind. Could it be lupus? Thank you very much.
Thank you so much, Dr. Aisha Latif, for your informative presentation.
Thank you to all our speakers and panelists for the enlightening discourse. The floor is now open for questions. You may hand your questions written on your question cards to a member of the hall committee.
Please raise your hands if you have a question, and we'll collect your question cards.
Thank you, Dr. Aisha. I've got a question from Dr. Aisha that how oftenly do we see proteinuria in drug-induced lupus?
Yes, that's a real question. Thanks, Robert, for a very good question. Proteinuria is rare, so I've shown you a case where there's a proteinuria on drug-induced lupus. Patients are not textbooks, right? I mean, Was she de novo lupus, which just got unmasked because TNF inhibitors were used? We will never know because there was no ANA done prior to TNF inhibitors. And I'm not recommending check TNF, every TNF inhibitor used. It's just that the clinical picture and the chronology, I have to run through the slides at the end. So there is a guideline that your drug should have been used for a month. There should be exposure history, and your symptoms should resolve after withdrawal of the offending drug, to label it as drug-induced lupus. That particular patient that I used to highlight is actually still on treatment. So it could be that she had lupus which just got unmasked by the use of TNF inhibitor, and it's not really a drug-induced lupus. So yes, it is unusual to have renal involvement in drug-induced lupus.
And regarding the first case, that was the parvovirus, don't you think that the case was so much typical of the lupus, and there was a history that she was a teacher and she might have a contact with, and there was no serology related to the parvovirus. Don't you think that these patients should be followed up in the OPD because they might be have underlying lupus, and presently they might be having some viral infection?
I would. So generally, we don't discharge people who have positive serologies. Again, I was just trying to highlight the cases, but yes, I will keep them in the follow-up and repeat serologies at least a couple of months to a year later. If they are still seropositive, at least in our setup, we keep them on our books, as we say, which is like at periodic intervals, we just hello, hi with them and make sure that they are not evolving. Yes, it could be an early seropositive patient where it came to light because she developed a parvovirus infection. But we all know that autoantibodies can be positive for a decade before a person develops a clinical manifestation, and not everyone who is seropositive will become a lupus patient. So at times, you have to keep the serologies, take it with a pinch of salt. Yes, follow-up is required. I would agree.
Thank you, thank you. The next question is from by Professor Abid Farooqi, and this is directed to Dr. Sarfraz Hasni. So the question is, ethical issues about predicting the onset of lupus without the ability to stop it from occurring. Should the patients be informed about their future?
So, very tough question. Of course, no doubt. So these are more to understand the pathogenesis, not for checking everybody coming into your clinic. But ethical issues are definitely there. So you have to have a clear understanding, because I think the number one thing is that whenever you order a test or you do an investigation, you need to know what are you going to do with that information. So I have to have a clear discussion with the patient that we're doing this. There is a possibility that you may develop lupus. There is a possibility you may not. But if you have IL-4, IL-5, IL-6 high and a positive ANA, the predictive modeling of that is that there is a high predictability that you may have lupus. But of course, very tough. I don't think there is a right or wrong answer here. Tough question.
Thank you. The next question is for Dr. Aisha. The question is, if someone develops drug-induced lupus with any drug, can we repeat the same drug in future or not?
I wouldn't. No, I wouldn't. That becomes a contraindication for that drug.
Professor Ahmed Saeed wants to ask a question.
So thank you for your always very enlightening cases. We keep on picking your brain, Aisha. So, so just sharing that, yes, other than anti-TNF, the drugs which we use to treat inflammatory arthritis, especially spondyloarthritis, sulfasalazine. So I have few case reports already which are in the literature, and series of cases which have been followed as ERA. So they actually, two of them out of like 100 after sulfasalazine, they developed proteinuria. They had a positive ANA. They had double-stranded antibodies, a full-blown renal involvement in lupus with an HLA-B27 background, and both had one sibling or one extended uncle or father who was having ankylosing spondylitis. So, and when the drug was withdrawn, like treated, they were rather treated for lupus nephritis, biopsy proven, withdrawn, they are like in remission for many, many years now. So even sulfasalazine can do. We all know that we hardly use sulfasalazine in patients with our patients in which we are having a even a suspicion that this can be CTD other than RA or SLE. So in your experience, do you use sulfasalazine in patients with ever in lupus?
I think it depends, right? If the predominant feature is arthritis, generally sulfasalazine, not really for lupus. It's more arthritis drug. And for arthritis also, most of us now prefer methotrexate, except when the woman wants to get pregnant or something, or there is a hepatitis, then I go for sulfasalazine. I always wonder whether we missed the initial diagnosis. If someone develops such an atypical feature, whether this was really a lupus to start with, but manifested as musculoskeletal manifestation and got treated with sulfasalazine, and later on evolved to a multi-system presentation. That's what I would consider. Would I ever use sulfasalazine in this patient again? Probably not, because there are just so many other drugs to use. Why to re-offend with the same drug and create further problems? And as we heard from Dr. Hasni this morning very elegantly, I mean, pathophysiology is not really very well understood. There are mechanisms that we don't know, and probably future will tell us. But at this point, having a full-blown lupus requiring renal biopsy, I will not use that drug again.
The next question is for Dr. Lewandowski by Professor Sumaira Farman. Your experience with cyclophosphamide in lupus nephritis induction in childhood lupus.
Sorry, I didn't hear the second part.
Your experience about using cyclophosphamide as an induction therapy in childhood onset lupus.
Thank you for the question. So I think this is maybe, you know, there's not, this isn't standard across all centers, and so I think where I trained, we used a lot of cyclophosphamide just for the reasons that I stated. Early onset lupus patients have a more severe disease phenotype, and when they have lupus nephritis, it's more likely to be severe. And so we used cyclophosphamide in many of our lupus nephritis patients. Sometimes, as Dr. Hasni said, we did do the Eisenberg protocol, where we combined cyclophosphamide with Ritux to reduce the overall dose. There is data coming out of CARA, the North American Collaborative Cohort now, looking more towards the Euro-lupus dosing in children versus the NIH dosing, so to reduce the total cyclophosphamide dose for kids. But we used it really frequently, especially in kids with lupus nephritis or CNS lupus. We did do ovarian protection with Lupron, and you know, in our experience, we saw very few cases of any adverse effects, including effects on fertility. So I saw 0 cases of that, and we used a lot of it. So that's my personal experience.
Thank you. As we are running out of time, this will be the last question. The question is by Dr. Tabe Rasool and directed to Dr. Sarfraz Hasni. Are there any markers for mitochondrial dysfunction leading to SLE? Question number 1. And are there any cytokines like IL-4 or 5 responsible for pathogenesis of lupus without involving the T and B cells, and may cause a seronegative lupus?
So for mitochondrial dysfunction, there are no specific markers per se, but you want to look at the reactive oxygen species are usually high, and then there are some studies that can be done. But those studies are done in very, on more of like a basic science labs. Like, for example, you look at the zebrafish studies where you can see that how much of the mitochondria is functioning. So there is an OCR, ACR, OCR/OECR ratio that you can get, and that will tell you about the mitochondrial dysfunction. But this is not something which is commercially available. And then the second question is about the second question was the
about the role of cytokines like IL-4 and 5 responsible for pathogenesis without involving the T and B cells and causing seronegative lupus.
Seronegative lupus. So seronegative lupus, I think, as an entity does not exist. So if somebody has a negative ANA, almost guaranteed that that patient does not have lupus. In fact, I was involved in the criteria development of the new ACR EULAR criteria, and then this was our biggest discussion. So as a new criteria, as you know, we have proposed that anybody who has a negative ANA will not be entertained for lupus. So that is an entry criteria, and now that was the consensus between all the lupus experts around the world, and that's how we come up with that. But the IL-4, IL-5, but I think interferon is pretty much what a lot of people are looking at. The problem is that interferon itself you cannot measure, so you look at the interferon stimulated genes or ISG, and to see if the transcriptome is showing that the interferon is stimulating the gene, because to measure the interferon itself in the blood is not that easy.
Thank you. Thank you. This concludes our session. Before moving on to the shield distribution, I would request our honorable chairs to give just brief comments about the speakers. Chairs, over to you. You can press the buttons. Yeah, yeah.
Bismillahirrahmanirrahim. Assalamu alaikum, ladies and gentlemen. Before I speak about the speakers' talks, here I would like to thank the organizers, Dr. Nigat Mir, Dr. Bilal, and their team for giving me the opportunity to join this Silver Jubilee conference. I would like to congratulate them for organizing this such a knowledge-packed conference and this amazing and so exciting session. And I feel myself very, very fortunate that I came this morning and learned a lot. I would also like to congratulate them for inviting the experts, world-renowned researchers, Dr. Sarfraz Hasni, Dr. Laura, and Dr. Aisha for this conference, and gave the residents and physicians here to learn from them, to learn from the experts. Again, I would like to thank Dr. Laura and Dr. Sarfraz on behalf of Vice Chancellor Fatma Medical University, Professor Khalid Masood Gondal, for sparing their valuable time for the Fatma Medical University and making our students and faculty wise. That was such an amazing session as well. As Dr. Sarfraz talked about untangling the knots, what I feel that lupus, as we all know, it's a multifaceted disease. But I'm sure that the researchers like you who are busy, who are dedicated for untangling the knots and bringing out the various mysteries which were still hidden, I'm sure that with this research, we are researchers like Dr. Laura, Dr. Aisha, and Dr. Sarfraz. They are working hard to make the lives of hundreds or maybe millions of people much better. Probably with their research, one fine day we will be able to make early detection, maybe prevention, not only the disease control, but maybe some cure. And once again, I'm thankful, and I wish you a very, very successful conference. Thank you.
Thank you. Thank you so much, Madam. Now I'll request Professor Samina.
Bismillahirrahmanirrahim. In the name of Allah, most merciful and benevolent. Assalamu alaikum and a very good morning, everybody. It was indeed a very, very exciting and a very, very knowledgeable session. And all the three speakers were amazing, simply amazing. And Dr. Sarfaraz, Dr. Laura, and Dr. Aisha Latif, really very lucid talks. I would say we learned a lot from your talks. And the last speaker, last but not the least, Aisha Latif, it's always a pleasure listening to you. And as the saying goes, always keep a low suspicion of index for SLE. This was the teaching, because SLE is, even now, a very underdiagnosed entity. And patients do not get diagnosed and get misdiagnosed, and they do not get treated, and they worsen. So the teaching used to be keep a low index of suspicion for SLE, but after listening to your talk, I would really say keep a low index of suspicion for the mimics as well. So I think we are always learning in medicine. So in the end, it was a great session. Thank you very much, everybody. Jazakallah.
Thank you so much, Jazakallah, madam. Now we'll start with the shield distribution, for which I'll request the chairs to please.
We will now commence the distribution of shields to thank our speakers, panelists, and our chairs. First, I would like to invite Dr. Shamsa Humayun to please present a special tribute from Fatima Jinnah Medical University. Can Dr. Laura Lewandowski please come to stage? Now, Dr. Sarfaraz Hasni. Thank you. Okay. Now you're going to call. You're going to call. And now call Dr. Professor Negatina.
I'd like to request Professor Dr. Nigit Mir and Professor Dr. Abid Farooqi to come onto stage and present the shields to our respected chairs. Professor Dr. Professor Dr. Shamsa Humayun. Professor Dr. Samina Ghaznavi.
I would now request all four of you to please remain on stage to present the shields to our speakers. Can Dr. Sarfaraz Hasni please come to stage? Dr. Sarfaraz Hasni. Dr. Laura Lewandowski. Dr. Aisha Latif. Yeah. And now to present the shields to our panelists. First, we have Professor Dr. Niga Tamir. Professor Dr. Abid Faruqi. And Dr. Shabnam Batul. Thank you so much. Our first session has now concluded, and session 2 will begin shortly.